Now I'm going to talk a little bit about therapy for the disease, and we're going to start to talk about adjuvant therapy versus neoadjuvant therapy for patients with a resectable pancreas cancer. So adjuvant therapy means receiving therapy after you've had the tumor taken out. Neoadjuvant therapy means that you receive the therapy prior to the tumor being taken out. And this can be in the form of chemotherapy, or it could be the form of radiation, or the combination of both. So one goal is to decrease the local recurrence of the disease. You want to try to sterilize the bed around in which the tumor existed so that patients don't have recurrence of the disease in those lymph nodes that are sort of draining the pancreas. And this is important to know that the patient has to have an R0 or R1 resection. What that means is that you are able to resect the tumor without having any tumor left at the margin in which is attached to the normal tissue as the tumor is being resected. This underlies the importance of having surgical resection at pancreas cancer centers where they do a large number of these resections and have an experience of dealing with the difficulties of surgery in this patient population. We also want to look at preventing distant metastases or delaying the development of distant metastases as well as recurrence. Once again, we can use different types of modalities to do this, chemotherapy versus radiation. So chemotherapy is a systemic treatment which treats your entire body, and this will be better in terms of thinking about treating distant metastases where we can't really see the cancer, versus radiation therapy, which is a local therapy, just as surgery is a local therapy, and really wherever the radiation beam is focused upon, that's the only area that's actually being treated. And so you can't really treat distant metastases or cells that you can't really see with just radiation alone. In the setting of neoadjuvant therapy, one of the questions is which patients will actually benefit from surgery. So there's about 20% of patients who have pancreas cancer are actually able to undergo the surgery, the pancreatic duodenectomy or Whipple procedure to remove the tumor. Of those 20% of patients, about 80% of those patients will develop distant metastases or recurrence of their disease. And so one thing would be, can we actually define the patients who will actually not develop distant metastases or recurrence and really not benefit from having the surgical procedure? And this is also thinking about the procedure itself is usually a 6 to 8 hour procedure. It's very difficult to recover from. It usually takes 6 weeks, maybe longer, for patients to recover from the surgery. And so we really don't want to put patients through undue stress if we can prevent that. And so by giving neoadjuvant chemotherapy, so this is therapy prior to the surgical procedure, some patients will develop either distant metastases or progression of their disease during that time frame. And so with that being said, then those patients would no longer be surgical candidates. And so if that patient would have had surgery right to begin with, they would have went through a huge surgery and then very shortly thereafter developed recurrence of the disease or distant metastases and really have not benefited from the surgery they had just gone through. So ultimately, the goal is to improve survival in these patients. So let's look at neoadjuvant therapy. This is really work that's been done and championed by the folks in MD Anderson in Texas. And what they did here was to use a drug called gemcitabine and combine it with radiation and do this prior to the patients having surgery. And what this graph is looking at is the overall survival in these patients. And so in those patients in which they underwent the chemotherapy and radiation, but when they did the analysis prior to surgery, the patients, for whatever reason, were not able to be resected, those patients' median survival was about 7 months. Whereas what you see here in the yellow are the survival for the patients who were resected. In those patients, the average survival or median survival was approximately 34 months, so significantly different. Now, if you combine all those patients together and ask the question, if you receive neoadjuvant chemoradiotherapy, what is the outcome for those patients? It's about 22 months overall survival. It then went on to ask the question, well, if we add chemotherapy to chemoradiation and really multimodality chemotherapy, can we improve the outcome of these patients? And so these patients received gemcitabine and cisplatin as well as chemoradiation with gemcitabine. So the overall survival in these patients was 17 months, so actually right around a little bit less than 22 months. So that would suggest that actually there is no benefit to adding additional chemotherapy to the chemoradiation. And if you look at those patients who received the therapy but were not resected, So that's these two patients here, this patient group in the blue, the patient group in the gray. These patients in the blue received chemotherapy plus radiation only, whereas the patients in the gray here received the chemotherapy with gemcitabine and cisplatin plus radiation. And their outcomes were actually worse than the patients who just received gemcitabine and radiation. And this is consistent with the patients who were resected as well. So the patients who were resected, seen here in the red or yellow lines, the patients who received just gemcitabine and radiation, they did better than those patients who received combination therapy plus radiation. So even the addition of combination therapy to the radiation of itself was of no benefit. And so what you can see here, if you just ask the question, those patients who were resected versus those who were not, who received the combination chemotherapy, you can see that these patients who were resected once again did much better. Their median survival was 31 months versus those who were not resected, their median survival was around 10 months.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.